Okay, hello everyone. Starting today, our first session about vascular diseases, surgical vascular disease. We will go through eMRCS. Okay, so start our question just now. Okay, start.
20 years old female has suffered from diffuse abdominal pain for the past 2 weeks since she was started on the contraceptive pill. The pain has increased significantly over the past 10 hours and has been associated with vomiting. Pregnancy test is negative. What is the most likely diagnosis? Mesenteric venous thrombosis, acute mesenteric embolism, chronic mesenteric ischemic, rupture ectopic pregnancy, inflammatory bowel disease. I think mesenteric venous thrombosis.
Okay, anyone has different answer? Can send in chat. Okay, Dr. Doppler said also mesenteric. Okay, so right, it is mesenteric venous thrombosis. So why we said mesenteric venous thrombosis here? Let's go back for the scenario. A young female has diffuse abdominal pain for just 2 weeks. Since she was started on contraceptive pills. So what he wants us to say by contraceptive pills, we will know later. The pain increased significantly over the last 10 hours and has been associated with vomiting. Pregnancy test is negative. And what is the most likely diagnosis? Okay, let's see the other options here. We have acute mesenteric embolus. Okay, maybe, yes, maybe. Chronic mesenteric ischemia. Let's go back for the history. It's just 2 weeks in a young patient. So is it a chronic problem? Actually, no. Okay, rupture ectopic pregnancy. No, pregnancy test is negative. So no. Inflammatory bowel disease. This is a chronic problem. So it is not the 2 weeks problem. So we have two choices now: mesenteric venous thrombosis and arterial acute mesenteric embolus, which is arterial. So I have here an arterial problem and a venous problem. Just 2 weeks pain. Is it something arterial? If the embolus happened, so this is something acute. Acute mesenteric embolus occlusion or arterial occlusion makes sudden onset of a problem. And we always see it in patients have thrombotic disease, like our embolic problems happens, like patient has AF, patient has rheumatic heart with vegetations. So we can find acute emboli happens maybe in brain, kidney, lung, intestine, anyway. But we just taking a short history of 2 weeks. And here he mentioned contraceptive pills. So he meant by contraceptive pills that the patient has hypercoagulable state. Hypercoagulable state. So this hypercoagulable state matches with the history of 2 weeks. There is some sort of thrombosis, but partial, until the thrombosis became complete. So the patient started to feel the ischemic intestinal pain. So say this is mesenteric venous thrombosis. Okay, we will have another question maybe soon. We'll find the symptoms that are like acute symptoms, and it will be something like arterial or acute mesenteric embolus. Okay. So unmute video, unmute video. Next question, Dr. Isra.
Okay, a 72-year-old man collapses with sudden onset abdominal pain. He has been suffering from back pain recently and has been taking ibuprofen. What is the most likely cause? Acute mesenteric artery embolus, peritonitis due to peptic ulcer disease, ruptured abdominal aortic aneurysm, bleeding, diolophy, lesion, pancreatitis.
Dulafoy syndrome, something French. Dulafoy
Yeah.
syndrome. Okay. Thank you.
Okay.
So what's your answer?
I would go with peritonitis due to peptic ulcer disease.
Okay, he has been suffering from back pain. So peptic ulcer disease make back pain?
No, he's taking ibuprofen chronically.
Yes, exactly, but he has back pain.
Yeah.
He's taking ibuprofen for the back pain.
Yeah.
And he has collapse. Peritonitis make collapse?
No.
Okay, so let's think about this question. The patient has collapse. So mostly something like shock, most like sudden bleeding, something cardiovascular. Collapse mostly happens like cardiovascular, hypovolemia, bleeding, shock. Okay, I think many answer in the chat. Yes, C. Okay, this scenario is a typical scenario for what's called abdominal aortic aneurysm. Exactly. Abdominal aortic aneurysm. Abdominal aortic aneurysm, the patient can come by many symptoms. This is an old patient, has a collapse. Collapse means the patient is hypotensive. So I found the patient collapsed, blood pressure is low, so the patient lost blood. So where he lost the blood? Let's go for a symptom. The patient suffered from back pain recently. Okay, one of the most common causes of back pain, abdominal causes of back pain is missed or undiagnosed abdominal aortic aneurysm. If we remember the abdominal aortic aneurysm, the aorta is lying direct on the vertebra. So when there is aneurysm in the retroperitoneal space, it compresses on the vertebral column and sometimes makes some erosion in the vertebrae and makes the back pain. And sometimes it is the main symptom that the patient comes. From what's called, we have a station in part B about back pain. And after you finish the station, the examiner will ask you, what do you expect the abdominal causes of back pain? You have two main causes of, you have to mention abdominal aortic aneurysm, undiagnosed or maybe diagnosed. The other cause is pancreatitis. So abdominal causes of back pain you have to put in your mind is pancreatitis and abdominal aortic aneurysm. Other like renal colic, sometimes make it like loin pain and referred like back pain. So the patient is complaining from abdominal aortic aneurysm, undiagnosed, old patient. The only symptom presents with the abdominal aortic aneurysm is just back pain, and he went to many orthopedic surgeons, and he gave him just make an X-ray or CT or something like this. The back is free, give him ibuprofen. The patient continued on just painkillers. And so the problem was abdominal aortic aneurysm till it's ruptured. And so the patient collapsed one time. So it's ruptured abdominal aortic aneurysm. Okay? clear or not clear? Okay, Dr. Doppler.
Yes.
Yes, this is a picture of the abdominal aortic aneurysm.
Yes.
You can see how it is just compressing the back. Okay, sometimes a patient comes, if he's a same patient or she's the same patient, she comes with pulsating abdominal mass, and sometimes come with back pain if it is not apparent abdominal. Okay, next question, Dr. Doppler.
40 years old lady presented with the surgical clinic with the symptom related to the varicose vein. She has noted that this is the first development when she was pregnant. On examination, she has truncal varicosity of the medial leg. There is no ulceration of this or skin change. A handhold Doppler examination demonstrated saphenopopliteal junction reflux. What is the most appropriate course of action? Offer the patient saphenopopliteal junction ligation. Offer the patient formed sclerotherapy of the saphenopopliteal junction. Offer the patient laser ablation of the saphenopopliteal junction. Arrange for contrast venograph. Arrange for duplex scan. I choose arrange for duplex scan.
Okay.
Because we should during any varicose vein should be search for patency for the valve. So I go arrange for duplex scan.
Okay, we already did Doppler examination.
But we do duplex.
Yes, that's what we need exactly.
Yes.
If anyone here is vascular surgeon?
I trained for 1 year. I trained in the 1 year as a senior house officer in the vascular surgery.
Perfect. So we'll get some information and some help from you today. Okay.
Yeah, thank you. Okay.
So if you are going to interfere, there is no vascular interference without investigation.
Yes.
Okay. So what we did today, I just want to clear the difference between Doppler and duplex scan. Okay, Doppler scan, just a voice, a sound you will hear by device, and this will tell you this is monophasic, biphasic, there is regurg or no regurg. Duplex scan, it is an ultrasound. We'll see the facial defect, size of the defect, numbers of the defect, and sites of the defect. If you are going to do a varicose vein surgery, it is very important to do, and you are planned for surgery, it is very important to do duplex scan for many things. First thing, to confirm that there is incompetent valves, whatever the saphenofemoral or any other leg junction between the deep system and superficial system, incompetent. Second thing, you have to confirm the patency of the deep system. No varicose vein operation without a documented duplex ultrasound that the deep veins of the leg are patent, because varicose vein may be secondary, and if you did the operation, you will catastrophe the situation. Okay, so duplex scan is very important in every patient having varicose vein, preoperative, to mark the sites of saphenofemoral junction or any incompetent junctions between the superficial and deep system. So you have to ligate. And the second thing, you have to clear that the deep system is patent. Okay? So, right, duplex saphenopoplar junction incompetence must image prior to starting treatment. So the first one, treatment ligation, second one, treatment sclerotherapy, the second one, laser ablation, and the contrast venography. Okay, some books had write that venography is a gold standard investigation for venous disease, but here we start with the non-invasive investigation, which is the Duplex Scan. And if we need venography, I think it is really done now for the dye and contrast material. Okay?
Yes.
Clear?
It's clear.
Please, if anything not clear, I can repeat it 1 and 2 and 10 times, no problem with me. Just to get the idea of the question. We are just now not solving question, blah, blah, blah. We are just taking the idea of each question and tell what's exactly wants you to know from this question. So you just fix the question in your mind. Any new person want to start, or we back again to Dr. Sahar?
I can continue.
Okay, just one by one, so no one get bored. Okay, Dr. Sahar again.
79 years old lady develops sudden onset abdominal pain and collapse. She has passed large amount of diarrhea. In casualty, her pH is 7.35 and WBC is 18. What is the most likely cause? Mesenteric venous thrombosis, acute mesenteric embolism, acute onchronic mesenteric ischemic, vasculitis, myocardial infarction. I think my answer acute mesenteric embolism.
Why did you choose this one?
Old age, sudden pain and collapse.
Passing large amount of diarrhea.
Yes.
Okay, this is a typical history of acute mesenteric arterial occlusion. Okay, if you found this patient, sometimes the patient pass bloody diarrhea. Okay, from ischemia, sudden ischemia. Sometimes the scenario come a patient in the ICU or ITU or HDU and coming after major surgery, or the patient is AF, or the patient has cardiac problem and developed severe abdominal pain, collapse, bloody diarrhea. This is typical scenario, acute onset, abdominal pain, bloody diarrhea, collapse, typical scenario, and I have seen it myself more than 2 or 3 times. The patient collapsed in front of me with bloody diarrhea. So this is acute infarction of the intestine, okay? So venous thrombosis, long history, acute on top of chronic, the patient have no old history of any problem, vasculitis, not cause collapse, myocardial infarction, not cause diarrhea. Okay, so maybe have abdominal pain with MI and collapse, but it doesn't cause diarrhea. And it doesn't cause the TLC or white blood cell count is high. So the right answer is acute mesenteric embolus. So you get the difference between the last 2 questions. Patient has 2 weeks history and then 10 hours history of pain and then started severe pain. And this history is acute onset of pain and collapse. So this one is venous occlusion and the second one is and the second one is arterial occlusion. Okay, so I'm sorry, I'm just muting all for noise background, and anyone wants to share or to talk, just raise hand and I'll open mic for him. Okay, so it's clear the difference between the 2 scenarios. Okay. Next question, doctor. Who wants to share? Dr. Isra, want to share again? Unmute yourself.
Okay. The medical team refer a 72-year-old lady with bilateral swollen legs. Deep vein thrombosis has been excluded and there is no response to diuretics. On further questioning, the patient reveals that she was born with a swelling in both of her legs. What is the most likely diagnosis? Lymphedema tarda, mixed disease, filariasis, lymphoma, or Mallory's disease?
This question is something you have to know about the different types of lymphedema. Do you know?
No.
Anyone know different types of lymphedema? So when lymphedema started here? Started
primary وسكندري. برايمري غالبا بتبقى حاجة congenital، لكن السكندري الكورس تاني زي الدي في تي أو زي الفيلاريو.
Okay.
So it is either
So
started
this case
from the first.
will be disease.
Yes.
Congenital.
So congenital, we have 3 causes. So this one is what's called Milroy's disease. Okay. Let's see the 3 different of causes of lymphedema, because the 3 questions come. Actually, 4 questions come about lymphedema. Okay. So first one is primary and secondary. Primary is congenital if happened before 1 year or at birth, so it is called Milroy's disease. If it is happened after the first year of life up to 35 years, it's called Meiggs disease. If happened later after 35 years, so it is called lymphedema tarda. So Milroy's disease less than 1 year, Meiggs disease after 1 year, and then more than 35 years, so it is lymphedema tarda. The other causes we'll face here also, we'll find a question about filariasis, and may we find one question about inguinal lymph node dissection or radiotherapy, I think, as long as I remember about this. You'll find the patient coming for an area endemic with like South Africa or some African countries, endemic with filariasis. So he will tell you the patient is coming from this country and this country is endemic with filariasis. So mostly the problem will be filarial lymphedema. Okay? Clear? All of these come in question, by the way. Milroy's, Meiggs, tarda, and filariasis plus 1 of the secondary. Okay. If anyone has noise background, please mute himself. Okay, next question. Who wants to share? Dr. Zaina wants to share? Or
Okay.
Dr. Doppler? Okay, Dr. Zaina, then
65
Dr.
years
Doppler.
old. Okay, 65 years old diabetic female, present with the Venus ulcer at the medial malleus. It has been present for the past 16 years. On examination, she has evidence of truncal varicosis and brownish discoloration of the skin overlying the affected area. What is the most likely cause? Chronic obliterative arterial disease, superficial venous insufficiency, deep venous insufficiency, mixed ulcer, neurovascular ulcer. I will choose superficial venous insufficiency.
Okay, anyone has any different answer? Why did you choose superficial venous ulcer, or why did you choose venous ulcer?
Characteristic of venous affection اللي هو brownish discoloration الهيموcyte deposition of the skin.
Site.
Was site
At the medial malleolus. The patient has symptoms of chronic venous insufficiency in the form of truncal varicosities for many years, Also, it is a painless ulcer. Okay. So it's superficial venous insufficient, or what's called venous ulcer. Okay, we just want to do good some hints about some types of ulcer we want to differentiate between. By the way, before and when there is EMQ or extended matched question before, this question can make you differentiate between many things. When you solve this question, sometimes it's helpful for you in the exam because he gives you the question like venous ulcer, arterial ulcer, neuropathic ulcer, malignant ulcer, and give you 3 or 4 scenarios, and you have to differentiate between. And this makes your brain is more clear about how to differentiate between different types of ulcer. So really, EMQ questions was very clear, and if you find time to solve some of them, it will help us to clear some issues. So venous ulcer is an ulcer mostly on the medial malleolus or above. The patient has some very chronic venous insufficiency symptoms for a long time. It's painless ulcer, hemosiderin deposition around with brownish discoloration. This is the characteristic of a venous ulcer. Arterial ulcer is a painful ulcer, painful ischemic ulcer. So this is the only one it will give you. Painful ulcer mostly will be an arterial ulcer, and this is characteristic for the arterial ulcer. And sometimes you'll find pallor of the limb or pallor around the ulcer. So this is due to ischemia. Neuropathic ulcer is the ulcer because the patient has peripheral neuropathy and the patient can't feel. So the patient can have a wound or an injury to his feet, to his leg, or to his back, and he can't feel it. And this progresses to an ulcer. And that's why we always find neuropathic ulcer on bony prominence. So we can find it on the heel, or sometimes we can find it on the sacrum. Sometimes, and the patient can't feel it and misdiagnosed by the family or misdiscovered. And sometimes we found it in the ball of the sole of the big toe, the big toe ball on the sole. We found also neuropathic ulcer. This is the most common sites for neuropathic ulcer at the start of the big toe, just at the ball of the foot, the sole, also on the heel, and on the back on the sacrum. This is the most common sites of neuropathic ulcer, and the patient mostly will be, he will mention that the patient is diabetic or having some neurological problems. And also the last one is the malignant ulcer, which is heaped up edges or everted edges, necrotic floor, irregular edges, and irregular boundaries. This will be, and long standing, this will be the characteristic of the malignant ulcer. And the malignant ulcer may be ulcer de novo, and most commonly will be on top of chronic long-standing ulcer. Okay, we have also what's called marginal ulcer. Marginal ulcer is the ulcer related to scars of old burn. Long-standing scar for burn, this developed an ulcer which is called marginal ulcer. Is ulcers clear or?
It's squamous cell carcinoma marginally.
Exactly, squamous cell carcinoma. So is it clear about ulcers, or I just repeat again?
Clear.
Clear, okay. So this is superficial, or this is a venous ulcer. This is the picture of the marginal ulcer on top of old long-standing burn. And this is what's called pyoderma pigmentosa, gangrenosum, which is infection and pus. Okay, next question. So who will want to share?
This is for
okay, back again for Dr. Sahar. Please, anyone wants to share, just raise hand. No problem. Most of them haven't read vascular before, so I just want to share. Read the question and don't answer to remember it. Okay, Dr. Sahar, start again.
52 years old obese lady reports painless grape-sized mass in her groin area. She has no medical condition apart from some varicose vein, clearance of impulse, and mass disappear or lie down. What is the most likely causes? I think my answer, Savina varicose.
Okay. Anyone has different answer? Any different answer? Okay. Right, it is saphenous varix. Saphenous varix is dilatation of the start of the saphenous vein at its origin from the femoral vein, or at its end in the femoral vein due to incompetent saphenofemoral junction. Why I didn't say false aneurysm of the femoral artery? Anyone has answered? Why I didn't say maybe false aneurysm?
False aneurysm, it's occur after infection or the trauma. There is no mention for them a trauma or infection in that site.
Okay.
So if we said a trauma, after that we develop the swelling in this area, so it's mean false aneurysm.
Exactly. Dr. Ahmed, unmute yourself. Dr. Ahmed Awaida, unmute yourself, and I did unmute for you. You can unmute yourself now. Okay, so from the scenario, the patient is old age, female, obese. Okay, all these are risk factors, and plus varicose veins. He just want to give you the risk factors of weak venous system. It's a typical history of old, female, obese, and she already have varicose veins. So the most common diagnosis with saphenous varix, and it just give impulse on cuff. If it is false aneurysm, it will be pulsating even without cuff, and the pulsation will increase with cuff. And also this is the mass disappear on lying down. Mostly false aneurysm, just the mass will decrease in size but will not disappear. Okay. And sometimes it has some skinny changes and some pain over the mass. Sometimes, not for sure to be have some pain. So the most common diagnosis here is saphenous varix. Okay, next question. Dr. Isra.
A 79-year-old retired teacher has had an ulcer for 15 years. It is at medial malleolus and has associated lipodermatosclerosis of the lower limb. The ulcer base is heaped up and irregular. What is the most likely diagnosis? Basal cell carcinoma, superficial venous insufficiency, squamous cell carcinoma, mixed ulcer, chronic obliterative arterial disease. Okay.
What do you think?
I think it's C, squamous cell carcinoma.
Exactly.
Because
It is.
yeah.
Yes. It's a typical picture of malignant ulcer. Okay, so it is on the medial. Exactly, squamous cell carcinoma. Okay, the ulcer is on the medial side and associated with lipodermatosclerosis. So it is a venous ulcer for a long time. Okay, so this is 15 years old ulcer on the medial side in a lipodermatosclerosis limb. So it is a venous ulcer, and now started to heap up and irregular. And this is a pathognomonic for malignant ulcer. So which is malignancy? Why not basal cell carcinoma? No, malignant ulcers on top of chronic ulcer. Mostly it is a squamous cell carcinoma from chronic irritation. Okay, not obliterative arterial disease, because it's not painful ulcer, because all arterial ulcers are painful ulcer, and this is a key point in your question to ask about or to answer it, arterial ulcer. Okay, next one, Dr. Doppler.
22 years old, professional tennis player attended the emergency department with a swelling, painful right arm. On the examination, his fingers are dusky. What is the most appropriate investigation? Chest X-ray, arterial duplex scan, CT angio, Venus duplex scan, Venus Doppler test. So I choose the second. I choose the arterial duplex scan, but I'm not sure.
Different answer.
Venus
also arterial. Dr. Zena say Venus.
Venus duplex.
Okay, what you doubt here?
It is sudden onset, so and painful. It's mean.
Here he doesn't mention it's a sudden onset.
Yes, swelling, painful. Yes.
Okay, swollen, painful, right arm. Fingers are dusky. So you are arterial duplex. So you are doubting some arterial problem, like occlusion.
Yes.
Okay, shouldn't the finger should be pale, not dusky? Okay, so here we are thinking about arterial problem or venous problem.
Thrombosis.
Exactly. It is very rare to find. Maybe in my life I did see upper limb DVT maybe twice or 3 times.
Yes.
More than 1,000 times I did see lower limb DVT. Okay, the same picture you'll find in the lower limb, you'll find it in the upper limb. You'll find the patient has dusky hand, dusky fingers. If it is something arterial, it will be severe pain, and at the same time, the fingers and the hand will be pallor of his hands. Okay, why Venus Doppler? Okay, Doppler, we just agree that Doppler is just a sound examination, voice or sound you can hear with the stethoscope, or just with your ear. But Venus Duplex, that's why you can just see the vein by an ultrasound on the vein. Okay, so it is Venus Duplex scan. This question is very important and repeated many times in the exam, by the way. Next one, Dr. Zena.
Okay. In which of the following operations are screw flapped excreted? Hand quarter amputation above knee, greatest tox amputation, below-knee amputation, Sims amputation. Below-knee?
Exactly. Below knee amputation. We have two flaps we do for below knee amputation, what's called skew flaps, or we do what's called Burgess flap or Burger flap. Burgess flap. We do these two flaps in below knee amputation. I think Burgess flap is just elongating the posterior flap so to cover a little bit anterior. Okay, what is hindquarter amputation? Anyone know? Orthopedic?
It's from the hip.
Okay, hip disarticulation.
Yes.
Hip. Okay.
Okay, disarticulation. Above knee amputation, no? Greatest tox amputation.
Through the knee.
Through knee amputation. And Sims amputation.
Through the ankle.
Through the ankle amputation. Okay, Sims, this is through ankle amputation. Greatest tox, it is through knee amputation, above knee and below knee, and then hindquarter amputation, which is a hip disarticulation.
It's arranged or normal as a limb.
Sorry?
We can arrange like we thinking about a limb. It is from the above to down.
Exactly.
Yes.
Exactly. Okay. Next question about the ABPI. We'll start with Dr. Sahar again. Anyone new wants to share, please raise hand. We're only 4 sharing now. I need more to share. Okay, Dr. Sahar, go.
What is the ankle brachial pulse index measurement shown below is most likely to be found in 83 years old man with wrist pain? I think my answer 0.6 between 0.8.
The wrist pain.
Less than 0.4.
Perfect, exactly. It is the least one, the smallest one, wrist pain. The patient has an ABPI less than 4 in critical limb ischemia, exactly. Here we just say it is 0.3, less than 0.3 the patient is critical and a half. But I don't have here in choices 0.3. So what is the next is 0.4. So it is the most common question. Again, this is very important. ABPI is very, very important in part A and part B. Okay. What is the ABPI? This is the ankle brachial pressure index. What it gives me the idea about the extent or the degree of the pathology and occlusion of the distal lower limb arterial system. What is meant how I do it? I take the blood pressure of the systolic pressure of the lower limb and divide it on the systolic pressure of the upper limb. So normally the upper limb is the upper limb. Normally the systolic pressure of the lower limb is a little higher than the exactly. Minute, please. Done. Normally, so if we found that the upper limb is 120 systolic, so we'll find the lower limb about 130 or 140 or something like this. When we divide these two numbers, we'll find it like 1.1 or something, 1.2 or something like this. So the normal, this is in any normal person, 1.1, 1.2 to find the lower limb. But if we found is this number or this index is little. So that's mean if I found it 1, that means that the lower limb is 120. So I have an arterial occlusion in the lower limb or arterial disease. If I found it less, so may I found it 100. So I found this index like 0.8. So it is less. So I have a problem, a vascular problem in my lower limb. Okay, so let's see what is the index or results of ABPI give me. Normal 1.2 or greater. This is this normal one from 1 to 1.2. This is the normal. If I found it less, if I found it less than 1 up to 0.8, so I have a minor stenotic lesion, or I have an atherosclerotic problem, or a problem, occlusive problem in the lower limb, but this is a minor problem, and go with conservative treatment. Okay, if I found this index is lit more, like 0.8 up to 0.5, so I have a moderate lesion, and I should consider start investigating about this lesion and start if it is need for intervention, minor intervention, or I will go with conservative treatment as well. Significant stenosis, we will find it 0.5 up to 0.3, and this is intervention is needed, or eventually will happen. A surgical or minor surgical intervention will be done soon for this patient. Less than 0.3, the patient has what's called critical limb ischemia, and the patient should save his leg as soon as possible. This patient has wrist pain and should have an urgent management, whatever, by bypass, stenting, or something like this. So these numbers you have to put in your mind. Normal from 1 to 1.2, mild up to 0.8, severe, moderate up to 0.5, less than 0.5 up to 0.3, it is severe stenotic problem, and less than 0.3 or the like the previous question, which is 0.4. So this is the patient is critical limb ischemia with wrist pain. Another question you will have it, he will tell you a diabetic patient, and the ABPI is 0.2 or 0.3, so it is more than normal. That means that the blood pressure in his lower limb is much higher than the upper limb, and this happens in atherosclerosis, or sometimes with visit calcification. And this also the patient will be mentioned in the scenario the patient is diabetic. So the patient is diabetic with ABPI 0.2. So it is a visit calcification, or he will ask you about the what do you expect about the ABPI. In diabetic patient, mostly the ABPI will be more than 1.2. Okay, clear?
That's clear.
Okay, so next question, I think Dr. Shi wants to unmute yourself. Dr. Shi, you can share, you can start.
A 72-year-old man present in the vascular clinic with cough pain, present on walking 100 yards. He's an ex-smoker and lives alone. On examination, he has reasonable leg pulses. His right dorsalis pedis gives a monophasic Doppler signal with an ankle brachial pressure index measurement of 0.7. All other pressures are acceptable. There is no evidence of ulceration or gangrene. What is the best course of action? Angioplasty?
Why?
He is symptomatic, and he has a brachial pressure index of 0.7,
Yes.
and he's in good health.
So
So and also
angioplasty
there's
for
no
what? What is the segment you'll go for angioplasty here?
or maybe
What do you expect the problem here in this patient? This patient is ex-smoker,
yeah,
old
he has
age.
the risk factor of yes.
So what you suspect the patient may have?
Peripheral arterial disease.
Okay. What's name in patient, old age, ex-smoker?
Sorry?
Patient ex-smoker. What is the most common disease comes in smokers? Berger disease. Exactly. I doubt in this patient that the patient has a Berger disease. Berger disease, so this is some sort of mild to moderate arterial disease affecting all the arteries, the small and medium-sized arteries, especially in the limbs and the arms. ABVI 0.7, so it is some sort borderline moderate. Okay, if we just have a look here, 0.7, maybe moderate stenotic. The highest to moderate, maybe minor to moderate stenosis. So in these cases, intervention is not preferred. So we start with conservative treatment and follow up with the patient. Okay.
Okay.
So angioplasty, bypass, and we will not leave the patient without medication because the patient already have some pain. So the patient has a complaint, not accidentally discovered. So we can watch and wait. So the patient has pain and I watch, no. So I have to give the patient conservative treatment and this sort of arterial dilators, a antiplatelet, antithrombotic, blood thinners. So it may improve the arterial flow through his vessels and improve his case. Plus the exercise, which is something of lifestyle modification for all patients with vascular problem. So conservative management with medical therapy and some exercise is the best answer here. No intervention needed in a patient with 0.7 with palpable peripheral pulse. Okay.
Okay.
Next question. Who will start? Whose turn? Dr. Sahar again?
Okay.
Dr. Isra, where are you? After Dr. Sahar, okay? Okay, start.
Wiltshire bound, 78 years old woman with ischemic heart disease, secondary to long smoking history and long-standing type 2 diabetes, present with wrist pain and non-healing ulcer on the dorsum of foot. Angiogram show reasonable superficial femoral artery and iliacus. At leafal popliteal artery, there is occlusion. Below the zero short area, patent posterior-tibial artery, and is reconstructed lower down the leg to flow to the foot. What is the best treatment option? Long subintimal angioplasty, femoral distal bypass graft with BTFA, above knee amputation, below knee amputation, axillary femoral bypass. I think above knee amputation.
Okay. Who think about any other question? Any other answer?
below knee.
Other answer?
So we have three answers.
Yes, exactly. Okay, this patient is old age, long history of
Above knee. Sorry, above knee.
okay. Let's say this patient old age, long history of smoking, and type 2 diabetes. So she have many risk factors for peripheral vascular disease, and she presents with non-healing ulcer in the dorsum of the foot. So she has started to have complication of arterial occlusion, which requires intervention. What is the benefit for, and the patient has heart disease? What is the benefit about giving the patient this an operation? Let's talk about subintern angioplasty. No, this is not for angioplasty. This is not a short segment. Femoral distal bypass graft with PTF. For what? She have a problem in all her vessels. She don't have, it doesn't mention that the patient have a stenotic lesion, in one part of her vessels or something, and he didn't mention the distal runoff and the proximal occlusion and something like that. Above knee amputation, below knee amputation. Axillary femoral bypass, also we don't have special segment here occluded, so we go for bypass. He should mention for me, we have occlusion in this place, distal runoff, and we have to say, okay, he mentioned here that the patient has good distal runoff, dorsal angiogram, prism of superficial femoral artery and the iliacs. The river posterior artery is occlusion.
Popliteal artery is occlusion. There.
Yes, below this short area of patent posterior cuff, but no benefit for this patient except for amputation.
Yes.
What is the benefit to give vascularity to a non-usable or non-healthy limb? Give for what? Give arterial supply. So this is a common scenario that gives you the patient is handicapped or the patient is wheelchair and old age and has many more comorbidities. He wants you to choose best option for this patient to give above knee amputation because there is a popliteal artery occlusion. So we normally, even for wheelchair patient, we don't do below knee amputation. We always do above knee amputation. So the patient, the only benefit for a patient on a wheelchair that you go for amputation, so the patient will benefit much more than you give or you make for her a vascular shunt or a vascular bypass or angioplasty operation. This scenario is unique, and he wants you to say amputation. Diabetic, ischemic heart, wheelchair, old age patient, go direct for amputation. Okay, this scenario come as it is, like this, without any changes in it. Next one.
Okay, a 24-year-old lady presents with a history of severe epigastric pain that is worse postprandially. On examination, the abdomen is soft and non-tender with no palpable masses. There is a bruit in the epigastrium. Imaging with the ultrasound shows no gallstones on OGD, and OGD is normal. What is the most likely diagnosis? Sphincter of OD dysfunction, irritable bowel syndrome, median arcuate ligament syndrome, mesenteric vein thrombosis, or gastroesophageal reflux disease.
It's a good question. This is very important.
I'm not
Let's
sure about the
see the
answer.
chat. Dr. C,
هي مش ماشية غير
Dr.
مع سي، بس أنا مش عارفة سي دي إيه أصلا.
This is the important note. Yes, see.
Yes,
لكن
exactly.
الباقي كله ما فيهوش نفس
Okay.
الهيستوري، ما يديش
Okay.
الكلام ده.
This is postprandial pain,
Mm.
epigastric pain, postprandial epigastric pain. When you examine the patient, you find normal abdomen, nothing, but you can hear a bruit in the epigastrium, and this is little to hear, or this is not frequent symptom to find, by the way, or sign to find. A bruit is very rare to find it in this patient. Ultrasound show no gallstones, no, and OGD is normal, everything is normal. Okay, this problem is narrowing or partial occlusion of the mesenteric vessels, mesenteric artery. Mostly the superior mesenteric artery or the inferior mesenteric artery, mostly the superior mesenteric artery.
Mesenteric, yes.
Okay. Okay. So you have what is called intestinal ischemia because of narrowing and decrease the blood flow through the superior mesenteric artery. What happens after food? The body tries to give more blood supply for the intestine during its digestive work. And so the narrowing of the superior mesenteric artery prevents this from happening. So some sort of relative ischemia happens for the intestine and makes the patient have pain, especially postprandial pain. By the way, this is one of the diseases that I think in Billis and Love said, you have to put in your mind this diagnosis to exclude to reach your diagnosis. One of the diseases, if you didn't put it in your mind, you will never ever diagnose. Okay?
Yes.
So any patient, really, I faced one patient about 10 years ago, and this patient is a close friend with me, and he tell me, I have an abdominal pain. And every day he comes for me after lunch. I have an abdominal pain. And I examine him, he's completely free. He did ultrasound, OGD, all the investigation and find not. And after about 6 months, the patient is discovered to have intestinal ischemia. And the patient went for operation and he resected a part from his intestine, and it is very rare disease that you find a patient have a narrowing of his superior mesenteric, whatever the narrowing is, like atherosclerosis or thrombus or something like compression by the median arcuate ligament syndrome. And this is very common. And I did see another patient with this same problem, but I have to put in mind, can you please make an ultrasound, duplex ultrasound for the superior and the inferior mesenteric? Ask the patient directly to do this if the patient is thin. If the patient is obese, he will go direct for mesenteric angiography to exclude this problem. Once you did exclude, you can search for any other problem. But if you didn't put it in mind, you will never diagnose this case. So this is a case of mesenteric or partial or relative intestinal ischemia postprandial due to compression by the median arcuate ligament on the superior mesenteric artery, making the blood supply to the intestine is much less, especially during digestive or during digestion and the GIT function. Okay?
Okay.
Clear? Okay, next question. Who? Okay, Dr. Doppler.
Yes.
And Dr. Shi. Okay.
72 years old man has a CT scan for abdominal discomfort, and the surgeon suspected abdominal aortic disease. It revealed 6 by 6 6.6 centimeter aneurysm with a 3.5 centimeter neck, and its continuity of right common iliac. The left iliac is occluded and the hypertensive and has type 2 diabetes mellitus, which is well controlled. What is the base course of action? Abdominal aortic repair in the next 24 hours. Abdominal aortic repair in the 6 weeks time. Review in outpatients in the 3 month. Endovascular aortic aneurysm repair in the 24 hour. Discharge the patients. I choose, because the size is more than 5, so I choose the first one. Abdominal aortic aneurysm repair in the next 48 hours.
Exactly. This is sometimes more than 5 and sometimes more than 5.5 if the
Yes.
patient has no other comorbidities. This is something like scale. If it is more than 5 and the patient has some other comorbidities, or more than 5.5 without any comorbidities, the patient should go for urgent or emergent repair. So the patient will be prepared within the next 48 hours to be repaired. Less than 5.5, the patient will have something like follow-up every 3 months, 3 to 6 months. This according to the schedule or according to the policy of the place.
According to size of your...
Sorry?
According to the size of the aneurysm.
Yes,
More
and according to the policy is to the place. More than 5.5, go for surgery.
Okay.
Less than 5, I think from 4 to 5.5, as the patient will have from 3 to 6 months follow-up ultrasound.
Follow-up, okay.
And also, if it is large, sorry.
Okay.
If it is large and the old age, more than the 80, so it is put in the conservative if not ruptures.
Yes, more than 80. So our scenario will be about 90 years.
Yes.
And ruptured, you will go for palliative treatment.
Yes.
Okay, next one. Who's? Dr. Shi. Unmute yourself. Okay, Dr. Sahab.
34 years old teacher at 10 a.m. with swollen leg. She has been in England for 2 weeks, having previous life in Democratic Republic of the Congo. She lives in area prevalent with mosquito and where there is poor sanitation. What is the most likely diagnosis? I think my answer A, malaria.
Filariasis.
Wait.
So can I answer this?
What is the problem with this patient?
Filariasis في lymphedema. Okay.
Okay, so the mosquito is one of the mediators for filariasis, especially in places like Congo. And
Escherichia Bancrofti.
Yes, Escherichia Bancrofti. As you, the patient, in the answer, this mixed disease, lymphoma, Milroy. So he is asking about malaria. Doesn't make, by the way, just make fever and hemolysis, but don't make swelling of the lower limbs. Okay, malaria don't make swelling of the lower limb. So here is a typical scenario of filariasis caused by a nematode called Escherichia Bancrofti, because maybe we found a question asking about it. Next question, Dr. C. Dr. Shi, okay?
A 23-year-old male suffering from hepatitis C presents with wide groin pain and swelling. On examination, there is a large abscess in the groin. Adjacent to this, there is a pulsatile swelling. There is no cuff impulse. What is the most likely diagnosis? So, I think it's there's no cuff impulse, pulsatile. Aneurysm of the femoral artery, maybe the true aneurysm of the femoral artery.
True aneurysm. It's come with pain and swelling if it is true aneurysm. Come with pain.
False of aneurysm.
The Safina Barracks.
No impulse of cuff here.
There is no impulse. What's an incarcerated hernia? Because
False aneurysm.
incarcerated hernia.
So incarcerated
Also,
hernia, severe pain.
severe pain, vomiting, abdominal
Emergency,
distension.
yes.
It's making an abscess. Abscess means infection, inflammation. So if true aneurysm, why there is an abscess and groin inflammation and infection? Okay, this picture is a typical of a young male IVDU intravenous drug user that have several injections or have indwelling injection, mini injection in the femoral. And this is a very common site for intravenous drug users to give injection in this area from repeated trauma by the needle. In this place, sometimes he perforates the vein, sometimes he perforates the artery. So the patient, also he uses unclean needles. That's why the patient is hepatitis C. And sometimes maybe he tell you the patient it's HIV. So all these tell you that the patient has multiple trauma with infected material to the artery. That's why the patient will develop a false aneurysm or infected aneurysm of the femoral artery, which will give a picture of pain, swelling, and sometimes gives a picture of abscess formation with discharge. Okay, by the way, so it is a false aneurysm of the femoral artery. By the way, this station or this scenario cleared in part B because you have an examination station about a patient referred from his GP by an inguinal swelling, and the GP will refer this patient like an inguinal abscess to open for incision and drainage. And from your history and from your examination, so this is a history station. From your history, you'll find the patient he's young, he's intravenous drug user, abuser, and the patient has HIV. And you will, from your history, you will discover that it's a false aneurysm because the patient will tell you, I always give injection to myself in this place many times and with shared needles between he and his friends. So it is a common site of infection, HIV, hepatitis C, and the patient will develop false aneurysm of the femoral artery, okay? This is a scenario in part B, by the way, a complete station, history station in part B. Okay, next question. Who? Dr. Doppler?
Yes. 71 years old man presented with painful lower calf ulcer, mild pitting edema, and ankle brachial pressure index of 0.3. What is the most likely cause? So it is severe stenosis. Oh, the option: mixed ulcer, deep venous insufficient, chronic obliterated arterial disease, squamous cell carcinoma, and neuropathy. So from the question, it is a painful ulcer and severe stenotic. So I choose chronic obliterative arterial disease. C.
So what is the type of ulcer here?
It is arterial.
Exactly.
Yes.
So this arterial ulcer.
Yeah.
Arterial ulcer with ABPI 0.3. So this is severe critical limb.
Yes.
So this is an arterial problem which will not match with any other option like mixed or venous or malignant ulcer or neuropathic ulcer. Neuropathic ulcer is almost always painless ulcer.
Yes.
Okay, so I think it's clear question. Okay, next one, Dr. Who? Dr. Zaina.
Okay. 6 years old man admitted with wrist pain and foot
63.
ulceration.
63.
Hmm? 63.
63.
Okay. Old man admitted with wrist pain and foot ulceration. Angiogram shows 3 centimeter area of occlusion of the distal superficial femoral artery with 3 vessel runoff. His ankle brachial pressure index is 0.4. What is the most appropriate course of action? Conservative management with medical therapy and exercise, arterial bypass surgery, arterial bypass surgery using vein or BTFE, primary amputation, angioplasty. Angioplasty.
Why?
Short segment وفي good run off.
Okay, exactly. Okay, those who, okay, ankle brachial pressure index is 0.4, so is category in the severe condition, severe arterial. Yes, not critical limb ischemia, 0.3 maybe, but we just in severe occlusive arterial occlusive disease. So the patient is amenable for surgical intervention. Surgical intervention may be angioplasty or maybe maybe angioplasty and maybe bypass surgery. Let's talk a little bit about how I can choose between angioplasty and an arterial occlusion. We have what is called the occlusive site. So I have, let's make it like red. This is the vessel, and the vessel gives me what is called runoff. What is meant by runoff? Runoff, that means the site after the occlusion. Okay. Sorry?
Yes, with you.
Okay. If I have an occlusion here in this place, so what I'm searching for, I'm doing a duplex scan and search, is there good runoff after the occlusion? Runoff means there is patent arterial vessels I can depend on after the occlusion. So if I found the runoff is good, so I by the way, the runoff may be new vascularization, by the way, opening of new arterial or new obliterated arteries, small arteries. So I found exactly this picture in the angio. So I have a distal runoff good. Then I go back. What is the size of the occlusion? What is the size of the occlusion? If the size of the occlusion always in eMRCS or in the exam for eMRCS gives you about 3-4 centimeter occlusion, something like this or less. If the occlusion is small, we go for what's called angioplasty. Okay.
Yes.
If the occlusion is small about 3 centimeter, we'll go for angioplasty. If the occlusion is 10 centimeter or more, 10 centimeter or more,
So we
we
can
will go for what is called
bypass.
bypass surgery. Okay, is it clear? I'll open the mic for all. So if anyone feels that's not clear, just tell me again. Okay, we have to, if it's small, okay, again, occlusion. We have two things, small or short, sorry, short occlusion, which almost always will see it 3 centimeter, and sometimes long, which always sometimes it gives you 10 centimeter. Clear?
Yes.
The option here is angioplasty. Okay, mostly with stent. Okay, long segment. I have what is called bypass surgery. What's meant by bypass surgery? Bypass surgery means that I have this vessel and I have occlusion here, and this is long segment, and I don't have a stent to cover all these segments. So what I'll do, I'll get a graft, whatever it is, synthetic graft, what is the PTFE or the venous graft, and I'll do what is called bypass surgery. I'll bypass all this stenotic lesion, which is about 10 centimeter or more. I'll pass it with a graft, so the blood will go like this and go through the bypass and go. But what's most important in all this, that I have a good, so this is proximal, this is proximal, this is distal. So I have a good distal runoff. So when I make the bypass, I can find distal runoff. Okay?
Yes.
So we agreed, short angioplasty, long bypass. We have two types of bypass. Okay?
Yes.
We have what is called anatomical and what is called extra anatomical. Okay? Anatomical and extra anatomical. What is the difference between the two? Anatomical bypass, I will go with the normal anatomy of the person with doing anatomical surgery. So if I have, this is aorta, external iliac, internal iliac, external iliac, internal iliac, and then external go for femoral, and then go down to the leg, femoral, and then go down to the leg. And I have an occlusion, a big occlusion in the femoral artery. Okay?
Yes.
I have a big occlusion here. What is the anatomical bypass? The anatomical bypass, I do aorto femoral or iliofemoral. Okay? So I'm going to the normal anatomy. I'm going with the normal anatomy. Okay? But when I do, this is done in a healthy person, because it is a risky operation and a long operation. So agree, this is a risky long time operation and should be a healthy, fit patient. Okay? A healthy, fit patient. The other, what's called extra anatomical. This, I'm just looking, this is aorta, and this is the upper limb vessels, and this is the lower limb vessels. Okay, and I have an occlusion here, and the patient is unhealthy to do an anatomical iliofemoral or aortofemoral bypass. The patient can't bear a long operation and the patient is unfit. And what I'll do what is called axillofemoral operation. That will be more less in time and less risky. I will not go for the aorta through minor invasion, just go for the axillary artery and put the graft, and then subcutaneous, I'll connect the graft with the femur. So I'll do what is an extra anatomical or non-anatomical, exactly, if I want to say an accurate description for this, what is called non-anatomical or extra anatomical bypass graft. Okay, is it clear?
Yes.
Yes.
So short segment graft, long segment. Is the patient healthy? I'll do anatomical bypass graft. If the patient unhealthy or not fit for surgery, I'll do what is called extra anatomical bypass graft. Sometimes extra anatomical, I do femoral graft. Okay, I'll go for above the pubis and then from the femur to the femur. This is called also extra anatomical or non-anatomical. I always name it non-anatomical bypass graft. Clear?
Yes.
Okay.
What defines a good vessel runoff?
Good runoff.
Yeah.
Okay. Runoff means a patency. What's mean? By example.
I understand that, but if it said one runoff or three runoff, like, is there a cutoff point or something of the
No
number of
cutoff point. He will tell you good runoff and poor runoff. Good runoff and poor runoff. Just he will tell you the patient has poor runoff or no runoff. But in diabetic patient on wheelchair, old patient, ischemic heart, diabetes, long history of smoking, he told you the patient has good runoff, but the patient already has non-usable limb. The limb has no benefit. The limb is useless limb. Okay, the patient not using his limb, he's on wheelchair. What is the benefit to do a graft for this patient? For what? For nothing. So it is better for the patient and more health for this patient to do amputation. If I did for this patient graft and he is on wheelchairs, who is amenable for thrombosis or closure of the graft, and I'll go again to make another graft. So for this patient, the best option is amputation. Clear?
Okay. Yeah, thank you.
Okay. So, next question. Whose turn? Dr. Sahar, Dr. Isra.
60 years old Tibetan immigrant is referred to surgical clinic with painless neck swelling. On examination, it is located on the left side in anterior triangular. There are no other abnormality to find. What is the most likely diagnosis? I think carotid body tumor.
Exactly. It's by exclusion, by the way. Here, the scenario is short, so it is confusing a little, but just we are saying we have a swelling in the anterior triangle, so we just close to the carotid sheath. Let's talk, is it submandibular grand calculus? Should be in the scenario will be some pain, will be some bad odor of the mouth. Sorry?
And long history.
Long history. Stone calculuses should be pain.
Yes.
But this is painless neck swelling.
Yes.
Go for carotid artery aneurysm. He will tell you something like pulsating neck swelling, but he say painless neck. He will be clear. He will tell you pulsating neck swelling. Fibromatosis coli, not here. Laryngeal cancer, nothing in the scenario tell you the patient has cancer, cachexia, anorexia, loss of weight, sudden development of neck swelling, but he just referred by surgical by a painless neck swelling. Doesn't say it is a fast swelling or acute swelling or swelling of short history. Just from the history by exclusion, you can find that most likely this is a carotid body tumor. So here, even in the answer, he tells you the most likely diagnosis carotid body tumor. Okay. It is a unique question. You have nothing to confuse with this question, by the way, and I think it came in April 2019. Repeated question, by the way. Okay, just a swelling in the anterior triangle, painless swelling in the anterior triangle of the neck. Will give no other criteria because it has no other criteria. It is not pulsating, it is not painful, it is not of short time, it is not, it's just a swelling in the anterior triangle of the neck. Next question, Dr. Isra.
A 48-year-old woman is admitted with sepsis secondary to an infected diabetic foot ulcer. She has an necrotic infected forefoot with necrosis of the heel. There is buggy indurated swelling anterior to the ankle joint. Pulses are normal. What is the best course of action? Above knee amputation, amputation of the foot, below knee amputation, incision and drainage of pus, application of 4-layer bandages. I think B, amputation of the foot.
Who has a different answer?
Me.
Sorry?
Me. I said below.
Below knee amputation. Okay.
Because for me, I don't know. I doubt about my question, but support this. There's the fibrosis infection for it with necrosis of the heel.
Yeah.
So it's maybe involvement to the ankle joint. So for that, I prefer to amputate it above the knee, below the knee.
Okay.
Below
Why do
knee
amputation? Why do amputation? Why I don't give the patient like incision and drainage and medication?
Because it's sepsis and infected for that
Exactly.
or
Exactly. The
necrotic.
patient is in sepsis, already in sepsis,
Yes.
and she has a necrotic infected forefoot, and she has necrosis of the heel. So the patient is going for a charcut foot
Yes.
with infection. So no benefit for after bony necrosis to give the patient antibiotic. I can save the patient from the infection, but still I have a non-usable food. The food is unhealthy to complete, and with diabetes, the patient with, I think with diabetes, the patient will have recurrent infection from osteomyelitis. So the best is to amputate, but where to amputate?
Yeah.
Do I have something like foot amputation? We don't have something like foot amputation. We don't do foot amputation. We have what's called SIMS amputation through the ankle, and already the ankle is necrotic and infected. And we don't make amputation just above the ankle. It is not something like nonsense. We don't do this in medicine. Non-scientific amputation. So what is the scientific amputation here is below knee amputation. There is nothing called amputation of the foot, by the way. Nothing called. Maybe trans metatarsal or through metatarsal. Maybe if you have problem with the toes, and if you have problem with the metatarsal bone, you can go for SIMS amputation through the ankle. But what is unlogic is to go for just the amputation of the foot only. Okay, so this is named below knee amputation. Okay. By the way, we just forget to tell all other options we said about the short segment and the long segment, that depends on a good distal runoff. If I have a poor distal runoff, amputation is the fourth option to do in treatment of a patient with vascular occlusion. So I do angioplasty, I do bypass, or I do amputation, and this is the main four things in treatment for any vascular occlusion. We just enumerate them. We said conservative treatment. This is any scenario you will have conservative. 2 or 2 angioplasty. 3 will go for bypass.
And 4
Number 4 will go for amputation. Okay, this is your 4 choices in any patient with vascular disease: conservative, angioplasty, bypass, or amputation. Okay.
Okay.
Next question.
So, for me, yes.
Okay, then Dr. Zena, then Dr. Shi.
Okay.
Okay, go.
Okay. An 89-year-old man presents with hypotension and collapse and is found by the staff in the toilet of his care home. He is moribund and unable to give a clear history. He had suffered a cardiac arrest in the ambulance, but has since been resuscitated and now has a BP of 95 systolic. He has an obviously palpable abdominal aortic aneurysm. What is the best course of action? Immediate laparotomy.
Or
Or maybe palliation, because he's an 89-year-old man.
to repair the abdominal aortic aneurysm.
No, usually with an abdominal aortic aneurysm, we would go for laparotomy if the patient is not stable.
Yes. But the patient should be healthy.
Yeah.
Okay,
So,
you have an about 90-year-old patient, has a history of one arrest in the ambulance, and then
Collapse.
CPR, and the patient come back, and then the patient collapse, and mostly he will have an abdominal aortic aneurysm. Does the patient, this patient, we can do a repair for abdominal aortic aneurysm for few hours?
no,
No, risky patient.
no.
By the way,
So
the
what we will do?
repair take sometime 4 to 5 hours.
I know, exactly, for a few
Yes,
hours, not
yes.
less than up to 6 hours sometimes.
Yeah,
Like
just
it's more.
palliative treatment in this case.
This patient, what you will do for him? This patient is post-arrest patient with long-standing abdominal aortic aneurysm, neglected, and he's 90 years, previous arrest and post-arrest patient. This patient will be put in ICU or ITU with palliation, no intervention for this patient. This patient, if you started to intervene or to do any surgical maneuver, the patient will die on table.
Let him
With the
die in
first,
peace.
exactly, this patient will go in palliative treatment.
So I want to say some things. Any surgery after cardiac problem, we need 3 months, such as the MI or others. So here is arrest. So we need
No,
palliative. This is mean the palliative with this age groups. Okay.
yes, sometimes some urgent surgeries be done, but you should be ready in your operation OR by cardio resuscitation devices in the. This is another station, big station in part B about how to do an urgent operation for a patient with cardiac disease. Whatever the patient has a big cardiac problem, what's your precautions, pre-operative, intraoperative, and post-operative? This is a big station in part B, by the way. You will do as an operation if it is urgent.
Yes.
If this patient is 60 or 70 years, he will do the operation,
Yes.
but with some precautions, pre, intra, and post-operative. Even you should be ready with all cardiovascular team and the cardio CPR equipment in your OR during the operation. But for this patient, age and post-arrest and collapse, so palliation would be the best choice. Okay, next.
For me or for whom?
Thank Dr. Zaina.
Okay. 35 years old Singaporean female attends a varicose vein preoperative clinic. On auscultation, mid-diastolic murmur is noted in the apex. The murmur is enhanced when the patient lies in the left lateral position. What is the most likely underlying lesion? Pulmonary valve stenosis, aortic valve stenosis, aortic sclerosis, mitral valve stenosis, tricuspid regurgitation. Mitral valve stenosis.
Mitral valve stenosis, mid-diastolic murmur. Why?
And mid-diastolic murmur.
Where is the auscultation site? Apex. So you are
Apex, fifth intercostal space.
okay. So you are hearing the apex. The apex. What murmur you will feel the apex? What valve you are examining here? Let's revise again. Let's revise again.
Tricuspid to mitral.
Let's revise again.
Okay.
Second, third, fourth, fifth. Second, third, fourth, fifth. What is this area? What I sculpt here?
Mine.
At right
Sorry?
side, aortic.
This one. This, okay. Right? Left. What is
Aortic
this?
at right side.
Right side, aortic, okay. What is here?
Left side,
Pulmonary.
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 Pulmonary. Here,
Mitral
fourth,
tricuspid.
Mitral.
tricuspid,
IT,
and fifth intercostal. Sorry?
IP, IT and PM. In the left side, yes. Pulmonary below it's a mitral.
Exactly. So I'm just hearing on the apex. So I should hear what is a problem in the mitral valve. Okay.
Yes.
Okay. It's clear now where I put my stethoscope to hear. So I put in the second right. So I am hearing an aortic. Second left, I am hearing a pulmonary. On the fourth parasternal left, I am hearing the tricuspid. In the fifth intercostal space, mid-axillary line, I am hearing the mitral valve. Okay, till now it is clear.
Yes.
So what is about the murmur?
Oh yes, this is
how I know the murmur.
So in the second, it's dependent on systolic or diastolic.
Exactly.
Yes. So for ejection systolic murmur, we put it in the screen. So
okay, just make it easy.
yes.
Make it easy. Just make it easy. I have what is most the problems we will have it in the aortic and mitral, and this is the most
Yes.
and this is the most problems that we will have. I just want to make simple. Okay, just make it like simple, like I just want to make what we do in school. So this is mitral. Okay, sorry. Okay, let's make it.
It looks like Valentine heart.
Yes.
Yes, exactly. Okay, keep it not Valentine heart.
Okay.
Okay, this is tricuspid.
Okay.
Okay, this is mitral. This is one is pulmonary, and this is aortic. Okay, but should be on the other side. Okay, so let's talk about a problem in the mitral valve. Okay, problem in the mitral valve here. We have two directions of blood here. Okay, during systole, the blood will go like this. Yes.
Yes.
From the ventricle. Sorry.
From the ventricle to the aorta.
From the ventricle to the aorta. If I found a murmur on the mitral valve during the systole, what should I expect?
So it's regurg.
Exactly. I should when during systole, so the mitral valve should close.
Yes.
And the blood should go through again. I'm trying to make it more clear. So this one and this one. Let's go for this heart. Okay, so this is the mitral and this is the aortic, okay?
Yes.
During systole here, the blood should go like this.
Yes, this way.
Okay, should go this way. If here on the mitral area and I hear a sound during systole, so
this valve
actually I having some regurg here. Okay,
yes,
just during systole, if I hear or I auscultate a murmur on the mitral area, so I have a regurg in the mitral valve. Okay, if I hear during systole a murmur on the aortic, so what should I expect?
in the systole or distal? In the systole, yes.
I'm talking all in systole now.
Yes. Okay.
Systole.
Early systolic murmur.
I hear a systolic murmur.
Yes.
Systolic murmur. So
okay.
What I should expect?
So the early systolic murmur occur in the aortic stenosis.
Exactly. So I should expect a problem here. So the blood during going like this, there is a stenosis. So during the systole on the second right intercostal space on the area of auscultation of the aortic valve,
yes.
I could hear during systole a murmur. So it is an early diastolic murmur of aortic stenosis.
Yes.
Okay.
It's clear for me.
Clear for you. For anyone, yes. Please.
For anyone.
Unmute all. Okay. Anyone wants to speak or wants to tell me, is it clear or not clear?
Yeah, it's clear.
So during systole, murmur on the mitral, so there's a problem of regurg because the blood will go back. Is problem in the aortic, so it is stenosis, so it is early systolic, so it is mitral valve stenosis. Okay, let's do it again like this also. Again like this. During diastole, and on the mitral area, I auscultate a murmur during diastole. What should I expect?
It's mid-diastolic murmur.
So, what should be?
It's mitral
normally
stenosis. Yes. Okay.
Normally, the mitral valve is well opened, so I shouldn't hear any murmur. So the blood should go clear during diastole. So I shouldn't hear any murmur on the mitral. But if I did hear a murmur, so I have some sort of stenosis of the mitral valve. So in diastolic murmur on the mitral area, so I have a mitral stenosis or calcified mitral valve, something like this. Okay, let's move my stethoscope and go up here and start auscultation. During the diastole, normally I should hear no murmur. If I hear murmur on the second right intercostal space, the aortic valve, and I did hear a murmur during the diastole, so this is regurg of blood. There is regurg of blood during diastole because the aortic valve should be closed during diastole, so I should hear no murmur. But if there is regurg, So I'll heal what is called aortic regurg. Clear?
Yes, clear.
I'm all now talking about diastole. Clear or no?
For me,
Clear,
clear.
clear.
Okay.
So 3 clear
Just
said.
it should be trained, by the way.
Yes.
Training. Just you have to draw the heart in front of you and see during diastole which valve should be closed and which valve should be open, and where you feel the murmur. If you feel murmur in a closed valve, should be regurg, and if you feel you hear a murmur in an open valve, it should be a stenosis. This is simply a murmur in a normally closed valve, regurg in a normally open valve, so it is stenosis. Next question.
So, for whom?
Okay, who can go?
Yes.
Okay, Dr. Daphne, go.
77 years old, morbid obesity man with type 2 diabetes presented with the leg pain at the wrist. His symptoms are worse at night and sometimes improve during the day. He has no area of ulceration, which of the ankle brachial pressure index measures show below is the most likely to be found. I suspect it is more 72 to diabetic. It is more 1.2. It is B, because the diabetic patient is sclerotic vessels, so it is presented as a high ABPI.
Exactly. Okay, this scenario is a typical scenario come like this.
Yes.
Old patient with diabetes, type 2 diabetes, leg pain at
the
rest, and the symptoms increase at night. Exactly. This is a typical repeated scenario. Typical repeated scenario, and it came for me in my exam. 77, old patient, type 2 diabetes, leg pain at rest, and the pain is more at night. So the APPI will be 1.2. Okay, more than 1.2.
For this question, any diabetic suspect it is the normal or above the normal?
Mostly, yes.
Mostly, yes.
Yes. Mostly will just. I tell you, this is a typical scenario.
Yes.
Okay, next question. Dr. Isra.
A 76-year-old man presents acutely 2 hours after onset with a painful right arm. He's right-handed. On examination, he has a cool right forearm and absent radial and brachial pulses. A duplex scan shows thrombus occluding the brachial artery. What is the most appropriate course of action? Administration of therapeutic low molecular weight heparin, brachial embolectomy with fasciotomy, intra-arterial thrombolysis, systemic thrombolysis, brachial embolectomy with fasciotomy.
Brachial embolectomy.
With or without fasciotomy? What's the answer?
I No idea.
It's 2
What do
hours.
you expect? Okay. Why you do fasciotomy? Fasciotomy, you do it for compartment syndrome. This patient has acute thrombotic ischemia of the upper limb, okay? Clear? This
Yes.
is acute ischemia of the upper limb. The patient has absent, not weak, absent radial and brachial pulse. The patient should go for urgent embolectomy or just embolectomy. We have to do urgent embolectomy for limb saving. I can't wait for administration of like low molecular weight heparin. It will take about 1 or 2 or 3 weeks for revascularization. So the patient within 6 hours should be saved. And the only thing to save this patient is intra-arterial embolectomy or brachial embolectomy without fasciotomy. I do fasciotomy if he tells me the patient is tense, painful swelling of the arm. That means that the patient in compartment syndrome. Okay, and mostly the compartment syndrome is the cause of ischemia. So here is the cause of ischemia is a thrombus, not a compression by the edematous muscles or intracompartmental edema. Okay, Dr.
Yes.
Doppler, you want to say something?
Yes, thank you very much. So from the hour, it's 2 hours. Any case, it's more than 6 hours, you should put the fasciotomy in your anterior.
If I have something like yes, if I have something like starting signs of
No, even not,
yeah.
because during this we lead to the swelling and extravasate, so it is starting on the compartment. So after 6 hours should be.
Okay.
We can't find this answer. We can't find this note in another question in the eMRC.
I don't think so, but I don't think that we will face another question more than this. But
I send this
very
one.
good, nice
Sorry
idea
to interrupt.
nice
So I'm very sorry to interrupt.
No. I just have benefit. I'm not a vascular surgeon, and I have
I
very little
find
vascular.
Yes, in some question in eMRCS, when I got it, I sent for in the group.
Okay, so more than 6 hours, we'll go for fasciotomy.
Yeah.
Okay. However, now I think we have more than 2 hours, so I think we have to stop I don't like the to have more videos than more than 2 hours, so it is to be easy for you to revise. So now I know we did take about more than 20 questions. I think it was 79, and now it's about 50. Yes, we almost done less than 30 questions, but today, because we illustrate every question, tomorrow I hope we finish vascular, because many questions will be repeated and we don't need to illustrate every question like today. Most of them you will find that something we did illustrate before. Thank you for today, and maybe tomorrow or after tomorrow we'll complete vascular surgery. Please revise these questions with the illustration, so tomorrow it will be easy and we take less time than today. Okay, I'll stop the recording.